clarification.
Our connection might be being weird.
We'll just go with Zoom. That's okay. So thoughts?
First that came to mind watching it is like the kind of I don't know the word for it, but basically like coattail riding on the fact that it was John Boyd's car, and that it was sort of like that, like I'm cool by association thing, and you would get upset whenever people insinuated that it was not. So that was John Boyd.
Yeah. Well, what's the parallel in psychiatry or psychology? Yeah, I think to start, understanding what is meant by an internal versus an external locus of control. So what are our initial thoughts on that?
An internal locus means that essentially you have control over, your destiny, and the things that happen to you are the result of your own work and your own doing. And then external locus of control is a belief that no matter what you do, there will always be external factors that result in things, and it almost like sort of parallels to the idea of like learned helplessness, where it's like it doesn't matter what you do or how you act, like there's always going to be external factors that have more of a power over your own fate than you do.
Yep. Okay. Any questions on that? Again, people who understand that irrespective of what others say about them, they're still the same person. Not, I mean, number one would have an internal locus, and not only aren't they at risk for depression and anxiety. Now, there might be other risk factors, of course, but regarding that singular risk factor, not only would they not be at risk, but they actually have a protective factor against anxiety and depression, right? Resilience. On the other hand, the exact opposite is also true with regard to risk for depression and anxiety. And that is, irrespective of who you are and what you bring to the table, you feel that your sense of self is largely determined by others' opinions of you, right? And I think medical students and other learners are great examples of this, because there are very specific situations in which I'm the only thing that matters for you in terms of the next couple of weeks, right? Your grade, your transcript, and your match, right? It will be greatly affected, in my opinion, of you. But despite that, most medical students, the vast majority of medical students, have an internal locus and also understand that no matter what he says about me, I'm still the same person. So you're able to not only understand that, but the dichotomy of that as well, and that is my grade, it doesn't change who I am, right? Questions or further discussion? So let's say somebody like George comes to clinical attention due to that anxiety and depression, and he starts talking about John Boyd's car and how frustrated he is, and perhaps even anxious he is, because other people now are debunking the fact that he has a famous actor's car. What's going through your mind in terms of how you best can provide care for that? Prozac dose start at 10, 20, 30, or D, doesn't matter. Yeah, why does it matter? Because the Prozac will never, ever change the faulty cognitive processing that is greatly impacting while your patient is depressed.
It's like the medication is probably do like cognitive behavioral therapy to change the thought process.
Yeah, especially if you see that pervasive pattern. I mean, if somehow this is in isolation and simply in a vacuum, might be one thing. But the mere fact that he's presenting suggests that it's probably more pervasive than that, and that pervasiveness is lending to clinically significant distress or impairment in his functioning. Right. Other observations for George. Oh, by the way, I'm going to, and this is only a clinical pearl, I'm not really sure it's true, Uh, you've heard me say probably around this table on more than one time now that the number of patients that you treat with medications for anxiety that you don't refer to therapy should always equal zero. So, I mean, incredibly low threshold, maybe a non-threshold um, with regard to psychotherapy referral for anxiety patients. Um, there's probably one exception to the rule, which would be what? Well, there's three exceptions to the rule. How many people here are going into psychiatry? So with the exception of one, the hint is that two of the exceptions you're not going to have to worry about because you'll intuitively address them, except for one person. So if they mention my program, we'll intuitively address it anyway. For Dr. Mintz's program. If your patient's anxiety is due to the physiologic effects of a substance, don't worry about referring to psychotherapy, get them sober. Or as an internal medicine physician, family medicine physician, you find that their anxiety is due to an underlying medical condition like SVT. Treat their heart condition, treat their underlying medical condition. Don't worry about getting them over to psychotherapy too quickly. And the third example would be an illness that is right now published and classified in the trauma and stressor-related disorder chapter of the DSM, which is called adjustment disorder, right? So if you haven't identified, well, actually, let me shut up. What is adjustment disorder? You do have to know the operational definition.
It's essentially clinically significant distress caused by the also a change in situation or a change in like an event that happens with I want to say 2 weeks after the event occurs.
That's my next question is that you said caused by. How does the American Psychiatric Association operationalize cause and effect?
I believe it's a positive sequence like for 2 weeks after the no.
It's within 3 months.
3 months. Okay. Yeah.
And was the second part of that?
Within 6 months of the stressor.
Yep. Yep. Yeah. And that's for board purposes. That's for shelf purposes. In real life, more stressors are chronic and enduring than they are acute. We're gonna test you on a definition, so we're likely to give you an acute stressor so that we can see its clear termination to test your knowledge of the symptoms then resolving within 6 months of that termination. If it's an enduring stressor, all bets are off, right? Clinically, that's much obviously more confounding situation. All right, so but if your patient has an adjustment disorder, if you identify that the onset was due to this, 2 credit course they're taking, and that the final exam is in 3 days, I'm not so sure that they have to refer to psychotherapy there. So, and the only time you would reconsider that would be after the exam, the person continues to be anxious, and maybe your provisional definition or diagnosis was incorrect. Okay. All right, other characters, Seifeld. Yeah.
For the exam part, if you have anxiety for the exam, but then you have a new exam, does that count as a new stressor?
Yes. However, I'm seeing a pattern develop, and it might be more test taking anxiety than it is you just being anxious over an exam.
Oh, okay, so if it's one exam, you don't do anything. If it's 2 or 3 exam, you do something?
Yeah, I think there, once a pattern is established, we have to get to more a different root cause than treat each individual exam as, because I think my patient then would be doing this, and that's not good provision of care. So what else is going on here? Maybe it's in the broader context of academic difficulty. There's a whole, I think, plethora of things I have to consider now. So yes, when a pattern is established, I think we need to go back to the books and see what might be going on. Perhaps treat a larger condition. Yeah, I mean, over the course of academic year, for example, I wouldn't want to diagnose you with, 14 adjustment disorders. All right, I have to have a little bit of a broader context and think there might be, one something rather than 14 separate adjustment disorders, right? Alrighty, other characters for discussion?
Well, if we want to talk about like locus of control, you could actually, I feel like kind of bring up mom and pop themselves. Because they're blaming Kramer on all these problems when they've been going on for God knows how long.
Yeah,
You know?
most definitely. And I think your observation, I think, pivots nicely to something we just discussed yesterday, and that is how to approach human behavior. I mean, it's a more general approach. Everyone in this room by now understands that we always have to consider and interpret human behavior and abnormal human behavior biopsychosocially. But we also should consider what predisposes, precipitates, and perpetuates illness behavior too, right? And along those lines, yeah, I mean, there were significant predisposing factors here, like decades long of neglect. The precipitant happens to be Kramer, right? So it's a great example of the 3 Ps of psychiatric formulation demonstrated in this particular episode with regard to what predisposed and what precipitates. So, and then you could see that the way in which mom and pop think, and therefore the way what they say, and even how they react and behave, in accordance with those 3 Ps, tells us a lot about them. Right now, again, it's in a vacuum, but when we see a more pervasive pattern, if they're consistently doing this, that means something else. All right, we'll end it here. Log off, log back on our second link.